So you're not going to be able to lyse a clot like you can with a stroke or a heart attack with a few minutes of TPA. Right? It's going to take some time. Right? So that's why the 2 hours does make sense. It's just not very practical when you're dealing with someone who's getting CPR, right? And you don't have 2 hours to spare. So this is what happened in this case. So we treated her with 100 milligrams because we did have a blood pressure that had come back up with the vasopressors. We had the time to do it. She got admitted to the ICU. She had some bleeding and oozing, which you expect from her IV sites, but no major bleeding. After 24 hours, her echocardiogram looked better, like we expected it to, right? Her vital signs also stabilized, and she was able to go to the floor. Okay, not bad. So that's our first case. Second case. Everybody good? Yeah. Questions?
Yeah, some. You said that in the beginning we give vasopressors to a person. How does that affect the left side of the heart? Does it help or is it a disadvantage?
It does help because it increases the left-sided pressure generally, which increases the coronary perfusion pressure a bit, which increases myocardial oxygen. And so the left side of the ventricle should, in theory, get more oxygen and be less ischemic and more functional. It doesn't necessarily reduce the pressure because you are going to increase your afterload a little bit with that, but you're also going to increase your preload a little bit, less so than you would with the fluid stuff. Okay, changing a little bit. Now we have a 58-year-old man who presents the emergency department with disc. So he's a little older. Remember, everybody younger than me is young. Everybody older than me is old. Right? I'm always just the right age. Presents with shortness of breath. He was on a plane, coming from a business trip. He felt short of breath. He went to get out of the plane. He felt dizzy, but he didn't lose consciousness. EMS was called, brought him to the ED. How are his vitals?
Okay.
Yeah, not great, but better than the last lady, right? So blood pressure is okay, heart rate's 111. One thing we'll often use is something called a shock index. You know what the shock index is? BP over heart rate, right? You take your systolic blood pressure, you put it over your heart rate, okay? It should be greater than 1. Some people reverse it and make it the heart rate over the blood pressure. But either way, your heart rate should be less than your systolic blood pressure, right? This one, it's about 1, so borderline, right? A little bit hypoxic, awake, looks short of breath, lungs again are clear. So, concerning for PE? Needs immediate thrombolysis? No, right? I wouldn't. Okay? So in this case, you get to do your CAT scan. Who could read this CAT scan? I'll give you a hint. There's a PE. What do you see? Are you familiar with reading CAT scans? Do you look at your own scan? Generally speaking, I would recommend you always look at your own scans. Right? You won't always be right, but you'll always learn something. Okay, so back to front, spine, aorta, pulmonary arteries coming across there, right? What's this? Clot. I'm too short. Your questions are taller than me. You may stand up here and help. What's that? What's this in here? Also clot, right? What is this going across? Still clot. Yeah, the answer is almost always clot. Okay, so clot going across, that's called a, you have a name for it in English? Saddle PE, right? Because it's just, we're the cowboys, but it's American. Right? So we sit on the saddle. That's a saddle PE. That one you can see a little better. What can you make out? Left ventricle, right ventricle. So if you look at the septum, which way is it bent? pushing towards the left. Normal, abnormal.
Abnormal.
Abnormal, right? So septum should be pushing towards the right ventricle. In this case, it's pushing towards the left ventricle. That means the pressure on the right side of the heart is high. Okay? Generally speaking, if the pressure in the right side of the heart exceeds 40 millimeters of mercury, the right heart will fail. It can, an untrained right ventricle is thought not to be able to push against more than 40 or 50 millimeters. Okay, so that's a pretty bad
Question, sorry.
Mhm.
You do the echo, what's the best case? I think this last one is subcostal, but in your experience, what is the highest probability that you're going to see that septum moving towards the left? Which point of view would be echo for you?
So I tend to like a four-chamber view. So that's what I like. I'm not primarily an ultrasonographer, I admit that. So you can see it on either a peristernal long, where you can see the right ventricular outflow tract, or you can see it on a four-chamber view. That's what I like. We have some biomarkers, right? D-dimer, not surprisingly high, right? Troponin, 58. We use a high sensitivity version now. We just did some studies looking at this because we don't know what the actual cutoff should be. We're going to talk about that in our third talk. But these are all somewhat elevated, right? So now, back to our ESC guideline. Where do we put this patient? Right, intermediate high, right? So this is not hypotension, it's not high. It's certainly not low. The right heart is certainly suffering, okay? And if you look at this back from, I'm sorry, this is the best version of this slide I could get. But this is a study that was done on the ICOPA registry by Niels Kucher a few years back. This here, this is patients with right ventricular hypokinesis. And you can see that over time the mortality approaches 20% or so, right? So this is one of the early studies that showed that right ventricular failure was a poor prognostic sign in patients with PE. And it suggested that some patients with PE might benefit from advanced treatments for PE. Okay? Now, of course, advanced treatments like thrombolysis are one thing, but what are we going to treat basically every patient with PE with? What should everybody think? No, not everybody gets thrombolysis. Heparin, right? Or some version of that, right? Anybody know who discovered heparin? Now that I asked the question, I forget his name, but that's not the point. The point of the story is not the name. So he was from my medical school. I went to Johns Hopkins. He was a second-year medical student. Yeah, so no pressure. Okay? Right? If you haven't done that by now, you're behind. Okay? Second-year medical student discovered heparin. All right? So, we're going to treat everybody with anticoagulation, right? There's a lot of different versions of anticoagulation now. Heparin is not a bad choice, okay? But we also have things like DOACs, right? We have things like fondaparinib, rivaroxaban, apixaban. They're all options now, okay? They have different properties, right? But one of the things that we found, oh, actually,